Course, and I would be talking to you about the current role of Tenon's grafting and amniotic membrane grafting in ocular surface reconstruction. So I put Tenon's first because you've already seen quite a bit of amniotic membrane. There are no financial or proprietary interests, and Tenon's patch graft we basically use for corneal perforations. So the size of the perforation is 3 to 6 millimeter. You can use Tenon's patch graft. You can use other options also like amniotic membrane grafting, conjunctival or corneal patch. But if the size is less, then you can glue it, and if the size is more, then you have to do therapeutic or tectonic BKP. Now, I'll just show you a series of cases of which we have done with the Tenon's patch. And the advantage and the idea of using a Tenon's capsule is that it has got anterior part of the capsule and posterior part of the capsule, and it has, if you look at the histopathology, fibroblasts in it which can cause fibrosis. So basically this is a case of desmetocele which is there. You can see that there are two of them. So Tenon's patch graft was planned for this case, so it is important to first make a sort of a, just define the edges or the margins where you are going to tuck in the Tenon's, and this is the area on the supratemporal side, and then it is placed here. Now the Tenon's is a very tacky tissue. It is like a you can say like a jellyfish. So it's a very tacky tissue. So what I do is I put a little bit of fibrin on it. So if you put a little bit of fibrin on it beforehand only, then the suturing becomes easier. Otherwise, what happens is with the suture itself, the Tenon's will also walk with it. So then it becomes difficult. The suture is pretty much like you would do a graft. So here sutures are put, and then just tuck it in the ledge which had previously been created, and then glue it up on the sides. And then air bubble is being instilled here so that the AC is formed. Now this is yet another case, a smaller perforation, and this is how the Tenon's was removed in this. Always need to suture this area from where the Tenon's is removed. Then again it is like a, like I said, it's like a jellyfish. It keeps moving and it's not very easy to suture. But in the pocket that had been created earlier, this is tucked in. This was a smaller perforation, so it didn't require sutures. You can just glue it up, and then AC is formed with the help of the air bubbles, and bandage contact lens is put on it. Now this is yet another case where perforation was there and it was AC was shallow, so air bubble is instilled first so as to form the anterior chamber, and this is being sutured here. And these are some of the cases. Over a period of time, even this opacity tends to fade away, and if it is not present centrally, then it is very good. You may not have to do anything else for this, and the AC is pretty much formed in the post-op period, and these cases do well. So in the armamentarium, when we treat for corneal perforation, this is yet another way in which we can treat patients. The advantage of Tenon's is that it is inexpensive, it is autologous, so there are no rejections. It doesn't cost anything, unlike amniotic membrane which costs. It is the patient's own tissue, so there can be no rejections, and it is very easily available. So in this next, what we did was we did a hitch suture technique, because sometimes it is difficult to tuck in the Tenon's, so you apply a suture here from one edge and then apply from the other end, just like you would do a mattress suture. And then just leave these two ends on one side, and likewise one can also suture on other areas. And after tucking in the Tenon's tissue, then you can remove these sutures, because the advantage or the function of these sutures is to actually push the Tenon's into the pocket that had been created, so that it gets pushed and comes right up to the edge. So once this is done, you can completely tuck it in, and then then put a glue on it, and then maybe you can even remove these sutures, because the job is already done and the Tenon's tissue is tucked in. So this is at the end of the case, and again all the sutures are now removed and air bubble is instilled so that the AC is formed. Now this was our publication on tuck-in Tenon patch graft and corneal perforation. It is best not to do in very active cases. In resolving cases you can do, and of course in sterile males one can do it very conveniently. This is in case of corneal fistula also. We've tried to do it and it has given good results. It was of immense use in the COVID times when there was nothing which was available. Then people have even used it for scleral necrosis following pterygium excision in two stages. One is Tenon's and then is amniotic membrane. And also this is a case where there was a melt in the tunnel, phaco burn was there. So people have used autologous Tenon plug for patch in the phaco burn as well. Now these are some of the post-operative photographs of the cases that we did, and most of them are, these are two cases which are paracentral, so it doesn't come in the visual axis. This was in the visual axis, for which we had to do a penetrating keratoplasty later on, and this was again in the periphery. So you can just get away without having to do anything if it is not there in the center. There are problems, there can be supratenons hemorrhage such as this, but then this resolves over a period of time. Sometimes you can have a pseudoterism. This had to be addressed because it was impinging the visual axis. If it does not, then you can just leave it like this. And then there was a Tenon's melt also, for which we had to do a graft. Now this is in 100 plus cases that we have done now. So these problems are there, but they can be managed. Now also in this case there was a pseudo-ectatic graft. It tended to protrude out much more. So cauterization was done of the graft here, and after doing the cauterization with the help of the cautery, the ectasia, the Tenon's graft flattened, and this can be again seen on the pictures here, pre and the post-op. Another case had cystic spaces, but this again went in for a corneal transplantation procedure. And this was impinging on the visual axis, so we had to do it. But as an interim procedure, it did help in plugging the perforation. So coming to the amniotic membrane, I think you've seen it all, except I'm sure Vanati must have shown you that it can be used for acute burns such as this, where you have to completely put amniotic membrane not only onto the ocular surface but also on the lids. And this, I want to just show you what a procara looks like, because this patient was rich, so the patient got procara from United States. It was imported, and it is nothing but a simulifron ring like this, on which the amniotic membrane is already there. So you have to just put it there, and the cornices are wide apart. That is the only idea, so that it does not form simulifron. Now, limbal stem cell deficiency, I think again Dr. Vinay Pillai has covered it very well. You can take the limbal lenticule such as this, and you can cut it into pieces. So if you are doing it in a lab, then it goes on the amniotic membrane, is again used for that. The cells grow in the lab in 14 days, and then 14 days later a cleft or cultivated limbal epithelial stem cell transplantation is done after clearing the pannus. So this is in the lab itself. On the membrane, the limbal lenticules have been cut and they have been grown, and the success rate of this procedure is 60 to 70%. And of course, slit, where again the pannus is removed, and once you remove the pannus, the glue is put, and then amniotic membrane acts as a ground on which the limbal lenticules are cut pieces of limbal lenticules are placed, followed by a bandage contact lens application. And you can defer corneal transplantation procedures such as this just by doing a slit which cleared up, and then we didn't have to undergo a PK. And all such cases, I think, first should undergo a slit procedure and then only corneal transplantation if there is a additional corneal gaze. Again, the success rate in these cases is 70 to 90%. Even from the multicentric trial, the success rates are higher, 83.8%. Then of course, COMET can be done, especially in bilateral burns, because you can't take the limbus, so we take the oral mucosa from the lower lip. And this is a case again of chemical injury from which the pannus is removed. And this is then cut into small pieces. On the lab, it is grown again on the amniotic membrane. And that amniotic membrane with these oral mucosal explants is then placed onto the surface, followed by a bandage contact lens. And even if you achieve a outcome like this, a patient actually bilaterally looked like this only. And this is a case of Stevens-Johnson syndrome in which COMET was done. And from hand movements, the patient gets 20/80 bilaterally, then it is one good thing for the patient. And there are no rejections. The surface is fairly wet, and the patient is able to move about. So that itself is success for that particular patient. And for simulifron, it can be reused to release with or without the mitomycin C. For pyogenic granuloma, sometimes you use when it doesn't resolve with the steroids. And this is a case of pseudoterism, wherein again amniotic membrane is being used. So when you are removing the fibrotic material, whether it is pterygium or pseudoterism, always pull it from the fornices and cut it flush so that whatever goes recedes at the back and doesn't come back again. And of course this is then glued with the help of the amniotic membrane on which the cells can grow. Then this is a keloid. Again, the keloid can be removed and amniotic membrane can then be placed on this also. There are lots of indications. This is a persistent epithelial defect, again on which a small patch of amniotic membrane is put and then a larger patch of amniotic membrane is put, so it causes epithelialization in the egg. Then you can have a Shields ulcer like this, which can be removed, and again a small patch of amniotic membrane is put here, followed by a larger patch of amniotic membrane as onlay, and this again responds. In any defect, this is a neurotrophic ulcer where small amniotic membrane patch is put, and then followed by this and onlay is put on it. So any of the cases, this is again neurotrophic ulcer where amniotic membrane has caused healing. I think it has the greatest role in Stevens-Johnson syndrome. Never leave a case of acute SJS without AMT, because we've shown in our randomized control trial that if you do AMT, the eyes look like this at 6 months. But if you don't leave them on medical therapy, they become like this. So to get a quiet eye and a white eye, always do amniotic membrane transplantation in acute SJS. Again, haze in those cases where it was not done. So there are a lot of myriad of uses for amniotic membrane as well as Tenon's graft, which I think both have an important role to play for surgeons, ocular surface surgeons, and otherwise even for general ophthalmologists. And they should be there in everybody's armamentarium. Thank you. Thank you, Sujit. Thank you very much for your attention.
I invite Dr. Sujit V. Nanar. His topic is Approach to a Case of Chronic Cicatricial Epithelitis.
May not prevent a lid margin keratinization, but it prevents corneal haze, it prevents so the lids will remain apart.